So we will now start our Test 3 exam review. Any pressing questions before I get into the prepared? I uploaded this online just recently, so.
So we're talking about the mechanism of action for antiarrhythmics. You're pretty much breaking it up into affecting the rate of the nodes and then affecting the rate of the rest of the cardiac tissue, right?
Yes, but it depends on the, kind of the class of antiarrhythmic you're talking about. So certainly, like, which ones are going to be more working on the nodal tissue?
Beta and calcium blockers.
Okay, so beta blockers, calcium channel blockers, which are which class antiarrhythmics?
2 and 4.
2 and 4. So which ones? So 2 is?
Calcium channel.
2 is beta blockers. 4 is
Calcium channel.
calcium channel, right? And which calcium channel blockers are they? Non-DHP, right? So I can't use amlodipine to treat an arrhythmia, right? I might actually cause one if anything. So so diltiazem, verapamil are going to be your 2 class 4 antiarrhythmics, okay? So those are going to be more working directly on the nodal tissue. Those are going to be better for your supraventricular tachycardias, or ones that are more originating in the atria. Say, things especially that have good strong conduction to the ventricles, so like A-flutters, things like that. It can help to decrease the rate, basically, right? So there's going to be more rate control, if anything. Then for your class 1 and your class 3, those are going to be more kind of all-purpose. Like, those can be useful for ventricular arrhythmias as well, because they're not really working on the nodes so much. They're kind of working on just the myocyte tissue, or that myocardial tissue, right? So type 1 or class 1 antiarrhythmics work primarily on what channel? Sodium, right? They should be working on sodium channels, right? And so we know that there's 3 different types of those. And then class 3 primarily work on what channel?
Potassium.
Potassium, right? So that's that potassium efflux. So keep in mind what different types of actions that's having on the actual electrical conduction happening within the heart. So like the sodium channels are really responsible kind of early or late in the action potential phase?
Early.
Very in the early phase, right? So that's why you're kind of prolonging all aspects of the action potential, right? Because you're kind of stopping it from the very beginning, so your PR, QRS, QTC all get somewhat prolonged, versus where you're looking at potassium channel blockers. What are those primarily doing? Yeah, they're more going to be seeing like in repolarization. You're going to be seeing elongation of the QTC primarily, which also means they're more at risk for what type of arrhythmia? Torsades as well, right? So that's the other thing you're kind of having to balance out with that. What beta blocker falls into class 3?
Sotalol?
Yeah, sotalol is the one, right? So sotalol actually has potassium channel blocking activity. So that's one you actually will see used more frequently for arrhythmias, and you'll never see it used for like hypertension or something, right? Because it has that antiarrhythmic activity. So that's kind of the main kind of differences there. And obviously you have your kind of random classes, ones like adenosine, digoxin, things like that. They don't really kind of fall into that same kind of category, right? Or the same kind of classification, that Vaughan Williams classification that we saw with the other groups, right?
So just to summarize, nodal is for atrial and
You just basically like supraventricular tachycardias, right?
Okay.
That's primarily we're going to see them being used. Because again, if I have an arrhythmia that's originating within the ventricles and I have some kind of reentrant arrhythmia happening there, if I'm blocking the nodal tissue, that doesn't really do me any good, because the ventricles are still the ones that are generating that abnormal propagation, right? So I need to use something that's going to be more all-purpose and work just on directly on the myocardial tissue. And so by giving, say, like a class 3 antiarrhythmic and extending that refractoriness of those tissues, I can hopefully help prevent that reentrant rhythm, right?
So what's the thought process if you have a ventricular arrhythmia picking between a sodium and potassium blocker?
So typically what you'll end up seeing is that, and my thing, obviously I'm not a cardiologist, right? So I'm kind of going at it from like more of an emergency medicine perspective and kind of what we see there. So very frequently for seeing like, emergent treatment of ventricular arrhythmias, like amiodarone is like one of your go-to drugs, right? So usually going to be one of the go-tos. But in some cases, like if you were to look at like advanced cardiac life support guidelines, for a long time, lidocaine used to be kind of an alternative to amiodarone, right? So you sometimes use that. Lidocaine was nice because it worked preferentially in what type of tissue? Like injured, ischemic tissue, right? So that was kind of the benefit there. If you're a patient having MI who's having ischemic tissue forming, like lidocaine would preferentially work there to help, deal with those reentrant rhythms. But nowadays, amiodarone is kind of like your go-to drug, right? So then it gets kind of more of a question where you have things, if you were converting someone from like AFib over into a normal rhythm, frequently you'll see like your your class 1 antiarrhythmics being used. So things like flecainide, propafenone. Sometimes you'll see some of your 1As working, things like that. So again, it's going to depend on the cardiologist. It depends, obviously by reading the EKGs, they can get a much better sense for kind of what's going on. And so you'll see certain drugs being used preferentially for different types of arrhythmias. But at least for my purposes, at least I want you to have the mechanism under control. So that way you know that, if I was dealing specifically with, a ventricular arrhythmia, why doesn't a beta blocker work for that, right? That's kind of the concepts I want you guys to be able to take away from the lecture.
For us, it'll be like if we have to choose between two classes that affect the node, it's more like, okay, if he has like this and this and this, we don't want to give him this side effect, so we'll choose this one instead.
Right.
Okay, I got you.
Yes, because similar clinical cases of what you might see, like in some of the previous tests. Clear as mud? Yes, indeed. What other questions can I answer for you guys? You guys are all studied up. You can take a test now if you want. It's all done. Okay. So I just made up a couple of questions off the top of my head to kind of generate some discussion here. So let's say you have a 64-year-old female who has a history of CHF, MI, angina, asthma, type 2 diabetes. She is a certifiable mess, right? So this is a perfect patient, though, because this is going to be important to help us decide what type of medications we want to use for a patient like this. So say we want a medication to help control her anginal symptoms. What type of medication do you think you would use for a patient like that? So her beta blocker, why is beta blocker a good choice? Nope. Well, let's hang out on the beta blockers for just a minute here. So why would beta blockers be a good choice? Okay, so good. It can decrease O2 demand on the heart. What other kind of compelling comorbid condition does she have where beta blocker would be useful? Previous MI. What else? CHF, right? Because we talked about certain ones can actually have mortality benefits for CHF, right? So there's actually some important mortality benefits we can get away by using a beta blocker. So the important thing here is you have a patient who has asthma and has a compelling indication for a beta blocker. What type of beta blocker should we use? Yeah, cardioselective ones, right? So do you guys remember back when we talked about CHF, what are the three indicated beta blockers that we mentioned there for CHF? Carvedilol. So here, carvedilol, what's the next one? Metoprolol XL, right? So that's important. That was one of the studies. So metoprolol XL, that succinate. And there's a third one. The B one, yeah, bisoprolol was the other one, right? So those are the three that were indicated, right? Which one of those would not you want to use? Would you not want to use? Again, speech is kind of impaired today. I smell toast too. Is that weird? So, anywho, so which beta blocker would you want to use for a patient who has asthma like this? Carvedilol? Remember, carvedilol is kind of that third generation. It's not necessarily cardioselective so much, right? So you may consider metoprolol, bisoprolol will probably be the other one you may want to consider. So keep that in mind. Like, remember, you want to use cardioselective beta blockers for an asthma patient. Good. So beta blockers. What other kind of compelling drug should we add on for control over anginal symptoms? Anything else? So ACE inhibitor, is that going to help with our anginal symptoms? So potentially, if they were saying failing, say they didn't have good control of their symptoms with a beta blocker, potentially you could put on nitroglycerin, like a long-acting agent, right? So keep in mind that there's controller medications, similar as what we saw for asthma, and then kind of your rescue medication. So regardless, if she has angina, she should be on some kind of rescue. What type of drug? Nitroglycerin, right? So she should be like, like a nitro spray or the tablets or whatever for kind of acute treatment of symptoms, versus where like the beta blocker is more going to be for control of symptoms and help improve her exercise tolerance, help to kind of prevent symptoms from occurring in the first place. So when the question comes up on the test, keep that in mind that there's a difference between control of their symptoms and actual treatment of the symptoms. Okay. Okay. So what kind of medication should she avoid as far as anginal symptoms go? What type of calcium channel blockers? Yeah, probably DHP if anything. You may see some increase in myocardial oxygen demand just by decreasing that total peripheral resistance. You could have increase in cardiac output. That's kind of a softball one. That's kind of one that, if she tolerated it, probably would be okay. If they couldn't use a beta blocker, even though that really has mortality benefits for a patient like this, potentially you could use a non-dihydropyridine. It could be another possibility. So keep that in mind. Let's say, what medication should she be on to decrease her risk of mortality from further cardiovascular disease? ACE inhibitor. Okay, what's that going to do for her? Prevents cardiac remodeling. Does it do anything else? Also kidney protective for a patient with type 2 diabetes. So again, we'll talk about endocrine stuff next time, but we already know that ACE inhibitors are going to be cardioprotective. What if she has really bad cough with it? Yeah, so to return ARB, right? So it's an example of an ARB. Losartan, candesartan, almost all your artans are going to be when they fall into that category. Good. What other things should she be on? Good. Aspirin, absolutely. That's good cardioprotective antiplatelet agent. Anything else she should be on? So specifically for cardiovascular disease, what are some other things that could provide mortality benefits for someone with CHF? So statin probably is going to be a good option for this patient as well, because that helps to kind of stabilize the plaques and prevent further development on that. It's a good one.
Loop diuretic.
Okay, so loop diuretics are interesting. So do loop diuretics actually do anything to mortality, or are they more for symptom management? Yeah, so keeping on diuretics are mainly going to be for symptom management, right? So they may be on a loop, they may be on a thiazide. Typically loops are going to be more potent. Sometimes you'll see a thiazide added on to help decrease some of that loop resistance for patients who are on kind of high-dose chronic use of loop diuretics. What would be the one exception to the diuretics use and mortality benefits in CHF?
Spironolactone.
Yeah, spironolactone, right? So and then alternatively to spironolactone, eplerenone is the other one, right? And what was the benefit of using eplerenone? Less gynecomastia, right? So that's kind of the big thing that that one gets recommended for as an alternative. It's usually more expensive, but as an alternative to spironolactone that can be used. And that's really only going to be for later stage CHF patients, right? So stage 3 or 4, they've already had some pretty significant cardiac remodeling done. Their ejection fraction is down. That's when you can initiate that. What are some contraindications to using spironolactone? I thought I heard hyperkalemia. Is that right? Yep. Hyperkalemia, right? So their K is already above 5. Because what's spironolactone going to do to that? Increase it. What other drugs did we already talk about that can affect their potassium? ACE inhibitors would do what to it? ACE should increase it, right? Because we're inhibiting that renin-angiotensin-aldosterone system. So ACE inhibitors should increase it, but what else might she be on that will decrease it?
Potassium-sparing diuretics.
Well, potassium-sparing diuretics would increase it, right? What would decrease her potassium levels? Yeah, her diuretics, right? So she was on a loop diuretic, thiazide diuretic. Those are all decreased potassium as well, right? So keep all these drugs interplays in mind here, because you want to be doing kind of frequent checks to see, especially if she has type 2 diabetes. Maybe she's had some nephropathy occur. Maybe she already has kind of poor kidney function. That's the other contraindication to using spironolactone for CHF, is if their serum creatinine is too high. Because obviously they're not going to be processing things like potassium as well. That would be another contraindication. What about digoxin? What does that do for our CHF patient?
I mean, it's symptomatic, right?
Excuse me. Yeah, that would be more for symptomatic relief. Yeah, no actual mortality benefit. How does digoxin work? Should increase contractility. Okay, so digoxin works how? What pump does it work on? Sodium, potassium, ATPase pump, right, exactly, right? So that's that active pump that's sending sodium outside of the cell and bringing potassium into the cell against its concentration gradient. That's why it's an active process that requires ATP. So by inhibiting that, you can end up increasing intracellular calcium concentrations, which increases contractility. But really what we know is that for CHF, we're using lower concentrations in order to deal with some of those neurohormonal pathways. So we're doing things like changing, decreasing sympathetic nervous system activation, and increasing parasympathetic effect on the heart to help relieve some of the symptoms there. So mechanisms, keep those in mind. So what else can I pull off of this? So as far as asthma medications go, what type of medications do you think she should be on at a baseline, at a minimum? So albuterol, right? So that's going to be what type of drug? Short-acting beta 2 agonist. Yeah, perfect. Short-acting beta 2 agonist. Good. So that's going to be for more control or for quick relief? Absolutely, quick relief. That's gonna be a good drug for that. If she was having, say, more persistent intermittent symptoms, what would be the next drug you'd want to add on for her? So now we're going to go just from more abortive treatment to more controlling type of medications and suppress the actual asthma exacerbation from occurring in the first place. What kind of drug can do that? Thought I heard it. So inhaled corticosteroids, right? That's going to be your next kind of go-to to help control symptoms. So inhaled corticosteroids are going to be useful for that. So your fluticasone, your budesonide, your flunisolide, things like that are all going to be your controller medications, right? Because they're going to help decrease the ability for your body to actually have that allergic response in the first place to cause that bronchoconstriction, right? So it's a good controller medication. What's a good thing to tell your patients to do after they use an inhaled corticosteroid? Right, because then they're at risk for what? Thrush, right? Because they're inhibiting that immune system there. Good. So say they were still having symptoms, they're on their inhaled corticosteroid, what would you want to give them next? So they've already been on a short-acting beta-2 agonist. Oh, now you should consider doing like a long-acting beta agonist, right? So you can use a combo med like an Advair, Symbicort, something like that, where you actually have the inhaled corticosteroid, and you're also going to have the long-acting beta agonist. As an alternative, what else could we do? Let's say we want to go a totally different mechanism.
Steroids for.
Well, that's going to be more for like a more significant exacerbation. So looking at the leukotriene pathway, we can use something like a leukotriene receptor antagonist, right? Because that's going to be something that actually can block a totally separate, pathologic process there to help inhibit that immune response. So, leukotriene receptor antagonists, like what would be a good example? Yeah, montelukast is going to be a good one. Again, not nearly as potent as something like an inhaled corticosteroid, but it certainly can help provide some additional coverage for that patient, right? And so they fail all of that, what else could they do? So certainly they can be in combination, but they're still having symptoms. Oh, you're close. There's a Z in it. So omalizumab or Xolair would be another good option, right? Because that's how does that drug work? It's a monoclonal antibody. Works against what? These are all really good things to know for like the test. It's like in 2 days, so just keep that in mind. So omalizumab or Xolair is a good one because it actually binds up IgE, right? So that can help decrease a lot of those inflammatory IgE antibodies that are causing the allergic reaction.
Just a random question.
Yeah.
Xolair in the office, why do they have to spin it on the centrifuge thing?
Because it takes forever to go into solution. It comes as a freeze-dried powder, as a lot of protein-based products do. It helps to increase the stability of it. Because like we mentioned before, if things are in aqueous solutions, they tend to be less stable, have a shorter shelf life. So it comes in as a freeze-dried powder, and it takes forever to actually get into solution. And proteins are tough because if you shake them, they start to foam up. And then when that foam is actually all your proteins that are coming out of solution and denaturing. So that's no good. And it's real expensive too. So you don't want to ruin your drug. I've never seen anyone use a centrifuge. Sometimes you'll see them use like a vortexer kind of thing. Kind of a funny story is that when you are treating snake bites in Florida, you'll use a drug called Crofab, which is very similar. It comes as a freeze-dried powder. It's the FAB portion of an antibody against snake venom. And so we were trying to administer some to a patient who has a very severe snake bite. Guy is hypotensive, is coags are all over the place, and they wanted to do 12 vials of Crofab. And so basically we tried to reconstitute all these, and you just like sitting there, you have these 12 vials, and you have the different pharmacy students who are just sitting there going like this in the ER, trying to get it back into solution. It just takes forever. But anyway, so that would be why you might use a centrifuge or something like that. Okay, any other options for asthma we could use? It's a lot of options, yeah, right. Yep, so potentially mast cell stabilizer. Those clinically don't use super often. Theophylline is also going to be one of those kind of by the wayside kind of drugs that you may see used infrequently for, say, like status asthmaticus. What's a really good sedative agent you can use if you had a patient with status asthmaticus? Yeah, ketamine is a good drug because it helps to increase catecholamine release. You see, decreased bronchoconstriction from that. So that's actually a really good drug that we'll use if we need to sedate and intubate a patient with that. Okay, good stuff. You guys know what you need to review, right? You do now. Perfect. All right. So again, just to kind of give you an idea, so remember compelling comorbid conditions and what type of drugs you may want to use for treatment of angina. If you had Prinz metal angina or that vasospastic variety of it, what would be your treatment of choice? What type of calcium channel blocker? The DHP, so your dihydropyridines or potentially a nitrate could be used for that, right? Because that helps deal with the actual spastic nature of it. Good. Okay, so what are some important patient counseling points for the following medications? We talked about the inhaled corticosteroids. How about the nitroglycerin patch? What's something, if you had to tell a patient one thing about nitroglycerin patches, they should know? Right, why is that? Tachyphylaxis, absolutely. Sounds like a pachyderm, tachyphylaxis, I don't know. But yeah, so again, you run out of those cofactors that are necessary for the nitroglycerin to work, so you need to have 12 on, 12 off. Because, if I wanted to prevent my anginal symptoms, I just want to keep a patch on all the time, but you need to educate them that's not appropriate. How about nitroglycerin tablets? Are there any important drug interactions you'd warn your patient about? Viagra, why? What can happen then? Yep, so hypotension can be a big thing because you kind of have both drugs both working on that nitric oxide pathway. The phosphodiesterase inhibitors are working to increase cyclic GMP, whereas the nitrates are working more by donating nitric oxide to help increase that pathway. Good. Okay, which of the following would be contraindication to the use of a fibrinolytic agent for acute MI? I heard you guys just talking about this before I walked in, so this is good overlap here. So let's say a patient had a blood pressure of 198 over 120. Would that be a contraindication? Receiving something like a TPA. So you didn't have a cath lab. You're coming in, you need to decide if you want to give them a fibrinolytic or not. So I heard a yes. How confident are you in that? Very confident, absolutely. So uncontrolled severe hypertension, absolutely do not want to give fibrinolytic to. Now I can give them an antihypertensive IV to try to drop that down, and if they gain control, then yeah, you could potentially give them a fibrinolytic. But as it stands, 190 over 120, that would definitely be someone you'd not want to give that to, right? Increased risk for intracranial bleeds, things like that, no good. How about a pregnant patient? Yes, that would also be a contraindication. You would not want to give that. Good, I know what you meant. If I hear them go no, and then I know yes, that's a contraindication. How about concurrent aortic dissection? That would be contraindicated, right? Because again, if they're having a dissection, increased risk for bleeding, not good. How about a patient with a brain tumor? Also contraindicated, right? Any kind of intracranial process, intracranial bleed, any of that's going to be no-go. How about a shellfish allergy? No idea.
Some of them have iodine.
So that one's not on the list. Again, usually these are recombinant products, usually producing like things like E. coli and things like that, but no shellfish are involved in the making of these drugs. Should not be as funny as it was. How about a history of GI bleed 3 years ago, secondary to the use of warfarin? Any contraindicated? 3 months, yeah. So again, look at your time frames. Again, typically you're going to be going over a checklist before you decide to give these medications, right? You'll frequently see this, especially for strokes and things like that, or ischemic strokes, where the neurologists are trying to decide whether or not to give the drug. They're going down the checklist, because again, if you give this to the wrong patient, they can bleed out and die. This is not a good medication to play around with. So just keep in mind, review that checklist so you'll know the obvious contraindications.
So was shellfish a contraindication?
That is not a contraindication. That was a red herring, as they say. Or a red lobster. Anyway, rock lobster. All right, I heard a question somewhere. Huh?
The shellfish question? Yeah,
Can that be on the test?
Yeah,
Maybe, I don't know. I haven't looked at the test in a while. Maybe it is on there. I don't know. Just kidding, it's not on there. Okay, so again, here's a list of the contraindications that were in the slide. So again, be at least familiar with these. If they're having acute dissection, if they're having any kind of active bleeding, probably should not receive this drug. That's kind of your kind of easy go-to. But some things that wouldn't really be super intuitive. The blood pressure thing, things like that. Be aware of those. Okay, so let's match the mechanism of the drug class. We kind of talked about this already, but we'll just hit it real quick. Inhibits potassium channels to prolong refractoriness. Class antiarrhythmic? 3, good. So what drugs fall into that category? Amiodarone. Sotalol, yeah, we go into that category.
Butylide.
Butylide? Are you looking at the list right now? No. There's another one, talk about dofetilide. That's kind of one of the newer ones, or Ticasin. That one's really interesting. So what's kind of special about Ticasin?
It's a strict blocker.
So it's a strict blocker. What should you be looking at before you start it for your patients? You need to check their electrolytes. If their electrolytes are goofed up, if their magnesium's not in the right place, if their potassium's not in the right space, you need to make sure those are in the right ranges, because otherwise you increase their risk for arrhythmias, right? So type 3s are really good for treating things like ventricular arrhythmias, for fixing atrial fibrillation, things like that. But again, they can all lead to other arrhythmias. So make sure the electrolytes are in place prior to starting this. There's also look at the renal function as well, right? So what type of test could I do that would tell me all of that? Yeah, a complete metabolic panel will be good to review that, so that way I know all the electrolytes are correct, the renal function's okay, and decide if that patient's contraindicated or not. Good. Blocks beta receptors? Class 2, good, we mentioned that, but sotalol is kind of the exception to that, because it's technically a class 3, kind of sits in both. Blocks calcium channels?
4.
Class 4, which is? Non-DHPs, so rapamyl, diltiazem, good. How about the inhibit sodium channels with affinity for the open channel? A and C, yeah, A and C would be the 2 there. So what falls into class 1A? Quinidine? PDQ, it's pretty darn quick, right? So procainamide, quinidine, and you said it? Disopyramide, yeah, those are the 3 that fall in that category, right? Which one will glow in the dark or glow under black light? Yeah, quinidine, right? Because it's a conjugate of quinine, which is anti-malarial. You find it in your tonic water, right? And then affinity for the inactivated channels? That's 1B, right? So there's 1A, B, and C, and then you have 2, 3, and 4. So class 1B would be what? Lidocaine, mexillatine, yeah. And how about your 1Cs? What's in that category? Flecainide, yep. Propafenone would be the other one, right? So be able to kind of put them in their categories there. Okay, and then how about activates the adenosine receptor? It's adenosine, yeah. It's right there, right? That was kind of tricky. So what type of arrhythmias would you use adenosine for? Yeah, PSVT, so paroxysmal supraventricular tachycardia, right? So that's one of those things where by inhibiting or hitting those adenosine receptors, you basically like shut down the nodal tissue completely. The heart just goes into asystole for a couple seconds and it comes back. Has anyone seen that before in the ER? How cool is that? Everyone's like, and then they come back and they're fine. And hopefully they go back into a normal rhythm, but otherwise, what's kind of the unique pharmacokinetics of adenosine?
Short.
Yeah, like how short?
10 seconds.
10 seconds, right? So it's really important to make sure they're pushing it in really, really fast, otherwise it won't make it to the heart. And then inhibits the sodium potassium ATPase pump. Digoxin, yeah, I remember digoxin. What are some side effects to let you know your digoxin level is too high? No, what causes kind of the bluish skin? So yeah, so for digoxin is like xanthopsia, which is that yellow, and you see the halos. What causes the blue-green skin discoloration? It's class 3. Amiodarone, right. It's a big one. It has such a long half-life, it ends up depositing in the skin, causing that kind of bluish discoloration that can occur there. Does anyone know any metal poisoning that can also cause your skin to turn bluish-gray? Not copper. It's actually silver. So if you ever heard of argyrism, that is, we have silver poisoning over a long period of time, and you get this kind of silvery skin discoloration. Look up a picture, it's really interesting looking. Some guy gave it to himself on purpose. Okay, so we already really talked about this as far as asthma treatment. How would you say COPD treatment kind of differs from asthma? Yeah, so the disease process is that it's not as reversible as asthma is, right? So what type of drugs would I focus on as far as treatment goes as opposed to what I did for asthma? So bigger focus on anticholinergics, right? So this is where like your tiotropium or your Spiriva, right? That wasn't even used for asthma. That's only used for COPD. You're typically going to use your steroids later on in the disease process. You're really going to focus more on long-acting beta agonists, long-acting anticholinergics up front, and then you can consider adding on things like steroids. But no montelukast, right? We're not going to do that unless they happen to have asthma at the same time. But strictly COPD, you wouldn't use montelukast or any of those leukotriene receptor antagonists. And then, again, focusing on the steroids after you've kind of maximized all their long-acting anticholinergics and beta-2 agonists. Okay. Good. Any medications you'd want to avoid? What was I getting at with that? I think we kind of mentioned. So again, no using like the leukotriene pathway drugs. Omalizumab is not going to be good for COPD, right? Because that's not really the disease process there. And then, how do the different smoking cessation aids help to increase chance of quitting success? So looking at bupropion, how did that work to help increase your chance for success? Bupropion, Zyban. What neurotransmitters does it help to increase? Dopamine, right? It helps to kind of tickle that reward center pathway a little bit because when you decrease your nicotine levels, you kind of depress that system by increasing levels of dopamine. You thought to help increase that to some degree and hopefully decrease some of those cravings they're going to have, right? How about the varenicline or the Chantix? What does that do?
That blocks the nicotine receptors partially, doesn't it?
So it activates partially the receptor, right? So it sits on there and only partially activates it. So that way when you lose that nicotine, you still have some nicotinic activity, but not as much as you would have if you were actually smoking, right? Can I use Chantix and smoking at the same time?
Yes.
Yeah, potentially you could. So typically like you plan your start date or your stop date 1 week beforehand. You start the Chantix, smoke for that week, and then you can come off the smoking, right? Gives a chance for the drug to actually kind of kick in, kind of get used to the side effects and whatnot, and then you can stop smoking, right? Okay. Looking at our chemo drugs, which ones are going to be linked to the specific side effects? So looking at peripheral neuropathies, what one do you think? Tell us it's going to be a lot of fun. We might be here till 6. So peripheral neuropathies, think about things like the vinca alkaloids, think things like paclitaxel, your taxanes. Remember, go back to your antineoplastic man. He'll kind of guide you as far as what the more common ones are going to be. How about a fatal pulmonary fibrosis? The B1, yep. Which one's the B1?
The B1.
Busulfan would be that B1, yep. It's good when you go to like your patients, you'll be like, we're going to start you on the B1. Yeah. They won't know the difference anyway. But. Okay, how about a hemorrhagic cystitis? It is a C1, yep. Cisplatin. So cisplatin can cause nephrotoxicity, but I'm talking about specifically hemorrhagic cystitis. It was one of the alkylating agents, right? Yeah, cyclophosphamide. Remember, because that one gets broken down into acrolein, right? The acrolein is really what's causing the issues there. We'll talk about that in a second. Ototoxicity. You just mentioned it. It's another C1. Cisplatin, yeah. So cisplatin, think nephrotoxicity, think ototoxicity. Good. How about diarrhea? Close.
No, Tecan, sorry.
Yep, irinotecan. Yeah, irinotecan's one of the big ones. If you look on on antineoplastic man, you'll see like 5-FU is also listed as a big diarrhea one, but really irinotecan's kind of the one I focus on. Cardiomyopathy. Herceptin. I guess yeah, potentially that could cause it, but more specifically,
Anthracycline.
Yeah, your anthracycline is what falls in that category.
Doxorubicin.
Yeah, so those antibiotics we talked about. So doxorubicin, daunorubicin, mitomycin, kind of all go in that category. Good. Nausea and vomiting. Yeah, almost everything. I'll show you a picture of that in a second. Kind of look at those antiemetic or the emetogenic potential for those drugs, but just realize almost anything can cause nausea and vomiting. But with all things, there is a scale to them. Some are much worse than others, as I'll show you in a minute. Bone marrow suppression. Yeah, pretty much all of them. How about opportunistic infections? Saying pretty much all of them can cause secondary infections or lead you to have secondary infections. Good. Okay, so what agent would I give to prevent toxicity from the following? What would I give for cisplatin? Prevent the hemorrhagic cystitis. Yeah, Mesna is the one agent I would give most commonly for that to help prevent the acrolein from causing the hemorrhagic cystitis. How about methotrexate? Leucovorin. Good. What's another name for that? Yeah, not folic acid, it's folinic acid, right? It's the activated form, right? How about cyclophosphamide? No. I'm sorry, you're right. I'm sorry, I got confused. Cisplatin, I'm sorry, cyclophosphamide is going to be the Mesna. The cisplatin is not, so what's going to be for cisplatin? I got confused in my C ones. Yes, there's potential. The other big thing is lots of fluids, right? So a lot of cases, by tanking them up with lots of fluids, you can help prevent a lot of like precipitation out of these drugs and things like that. So cisplatin, you'd be just really tanking them up on fluids, potentially get that sulfhydryl rescue with what drug? Yeah, amifostine might be a good drug. They could use there as well. Yep. Okay, and then daunorubicin. You mentioned that can cause a cardiomyopathy. So that one we give a chelator called dexrazoxane, right? So that would be the one you can give for that. Sorry about that confusion, but just so you know, cyclophosphamide is one you'd give Mesna for. Cisplatin is one you'd give fluids, amifostine potentially, that'll help prevent that nephrotoxicity.
Is the dextrose, however you say it?
Yep.
Is that for all the topoisomerase 2 inhibitors?
No, that's going to be for the anthracycline, so it's going to be like your doxo and daunorubicin. The topoisomerase inhibitors are which drugs?
The daunorubicin, doxorubicin, idarubicin?
Nope, those are the antibiotics. Yeah.
But don't they inhibit topoisomerase 2?
They're more working to directly kind of inhibit that DNA. They kind of indirectly work to inhibit topoisomerase. It's more that when the cell's using topoisomerase to try to repair those strand breaks, they can't really do the job because the drug is still sitting in there. There are other drugs that directly inhibit topoisomerase.
So what's their direct mechanism of action?
Remember, they're intercalators, so they will intercalate themselves into the DNA, prevent the binding of those base pairs, right? Okay. So just to give you an example, this is I pulled this off of NPR, I think, the website. Here's a list of different metagenicity potentials for different drugs. So looking at things like doxorubicin, greater than 90% frequency without antiemetics. Then you have moderate risk, low risk. Obviously, like a lot of our monoclonal antibodies, if you had to guess, where do you think they fit into? Usually low risk, actually. Monoclonal antibodies, because they're so targeted and they're so specific for their targets, they don't really cause a lot of systemic issues, right? So, but certainly things like doxorubicin, cisplatin's another big one, high dose cyclophosphamide. This is why you'll see patients on 4 or 5 drugs just to decrease the risk for nausea and vomiting associated with these, right? So we'll talk about more about those when we get to the GI section next semester.
So is there anything we need to take out of this giant
Yeah.
Just be aware of the fact that all the drugs can cause nausea and vomiting to various degrees, but I just want to kind of give you an idea of kind of the varying degrees of that, kind of how long it ranges. So you can see that, and this is why you always will kind of, a lot of protocols will already be kind of, they already have the antiemetics already selected based on the type of drugs that you're giving, right? So hopefully you don't have a whole lot of guesswork with that, but just be aware that, for something with a high emetogenic potential, your list of drugs you're going to get for that's going to be a lot different than something you can get for like low risk, right? But so just clinically, this is something that you'll encounter if you do oncology. Okay, so any final questions?
For the anti-cancer drugs, the ones that are like antigens or antibody related,
Yep.
Do those all cause allergic reactions? Or
Yeah, any kind of monoclonal antibody has the potential for causing allergic reactions. Yep. Yes.
Just to clarify on the entire cancer drug part, we don't need to know any of the interactions.
Don't know the indications. I'm not going to ask you which drug are you going to use for non-Hodgkin's lymphoma. That's not the question. It's going to be more based on adverse reactions, rescue agents, side effects, that kind of stuff.
Thank you.
Yep. Anything else?
Mechanism of action, did you say, or no?
Yeah, mechanism of action. Yep, absolutely. All right, see you guys next time.